Where do y'all work?
We're educators from Tyler, so critical care med surge.
Okay.
We're sort of just auditing to see what all y'all have put together.
All right.
So just lay it on us.
So I'm doing a full-on like wound vac application and service. Y'all want to get the whole deal?
Sure. Do it.
All right.
Yep.
So wound vac. So I like to start with going over how it works and why, because if you understand the components, where it works and how, then the actual dressing component is much simpler and it's kindergarten level arts and crafts. So VAC stands for vacuum assisted closure. The word drain is not in there. So a lot of people kind of wrongly assume that the drainage is kind of the main component of the vac. JP drain is much cheaper and much more simple if you just have drainage. The purpose of a wound vac is to grow new tissue and close a wound. So the way it does that, this is the basic, the granufoam. If you can see kind of through the light, you can kind of see through the edges. What the foam is it's made up of a series of all open pores. It's kind of like copper wire for electricity. As long as copper wire, as long as it's all connected, you can communicate electricity any distance. Same thing with the foam. When it comes in contact with the open soft tissue, we seal it off, hook it up to the negative pressure. It'll default to negative 125 millimeters of mercury. That suction pulls the patient's open soft tissue into those pores. That suction causes the cells to stretch and divide and replicate. Do you remember what that is from Biology 101? Cell division and replication. Anybody know? Mitosis. You got it. In a nutshell, that is what the wound vac is. It is a mechanical mitosis machine. So it is actually designed to pull the patient's tissue and for it to grow into the foam and get new granulation tissue. Also, this suction encourages angiogenesis, so that new blood supply comes to that granulation tissue, which is why the wound vac is known for that great red beefy granulation tissue. That's also why the wound vacs are indicated for the dressing to be changed every 48 to 72 hours. Because if you go longer than 72 hours, that tissue is growing into the foam, you go to remove it. Best case scenario, it's going to be very painful for the patient. You're going to remove all that new tissue you grew, and they're likely going to bleed. Worst case scenario, you're either not going to be able to remove it, or you're going to take it off and it's going to leave particles, and then the patient has to go to the OR for surgical debris. So that's why every 48 to 72 hours it has to be changed. When you do a dressing change, so you're going to cut the foam to fill the wound but not stuff it. You cut away from the patient so that you don't leave shavings in the wound that'll cause an abscess. And we want it to fill the wound but not stuff it. You want the foam to be open or puffed up when it's before you put the drape on there. If it's already crunched down, this is not packing. If we pack it into the wound really tight, those pores are closed off, the tissue can't grow into it, you're not doing anything. Also, the other way the wound vac works is when the suction is turned on, it literally pulls the wound edges in, and it can't do that if the foam is already compressed in the patient. So we put it in there. Black foam only goes where we can see it. It never goes into deep tunnels or undermining. That's what the white foam is for. If you have exposed vital structures in the wound, bowel, nerves, large blood vessels, cover those with Adaptic first, and then you put your foam in. All right, once the foam is in the wound incised, you get our drape. It comes in these large sheets. Essentially, it's Tegaderm that has 1 tab, 2 tab, and blue tabs on it to make it easier to apply. You cut it down to a size and shape that's appropriate for the wound. You want to use kind of the smallest piece you need. Every piece you cut, you have to have a 1, a 2, and a blue, or you can't apply it to the patient. So to apply it, take the 1 off. We call it drape because that's what you want to do. You want to drape it across the wound. If you pull it really tight and stick it down, it's going to compress the foam, which we already discussed you don't want to do. And it also, if you put it on the skin really tight and then hook it up to suction, it can cause shearing, and then we are damaging the patient's skin. So drape it on. Once you get that backing off, you can kind of press it down. 1, 2, the blue tab is last. This next part is the most important part and what most people get wrong about wound vacs. So this right here is what connects the tubing from the canister to the patient. There's little sensors in there that are monitoring the pressure in the wound bed, because at 125 we get is the best negative pressure for mitosis and angiogenesis to kind of be in sync. If you go a lot higher, like wall suction can do, you can go to 800. 125 is not anything special. Then if it's too high, you get the cells are replicating, dividing too fast, and before they get the blood supply, we get apoptosis, we get cell death. If it's too low, nothing's gonna happen. So these sensors that are in here have to be in contact with the foam. So the correct way is you cut about a quarter size hole in the drape. It's okay if you get a little bit of foam, it's not gonna do anything. The wrong way is to cut a tiny little hole or a cute little slit across. That's gonna give you alarms all the time. And then the tubing goes on the same way. There's a 1 and a 2 tab. That hole in the middle winds up with what you just cut. Press it down, the blue pulls back straight on itself. And then it attaches to the tubing. Hit start, and you're good to go. And it'll draw down. Basic troubleshooting, most common alarms are going to be a blockage or a leak. The pump will always give you an audible alarm. It'll give you an audible alarm, and a screen will come up with like a cartoon that shows you exactly what to do. If it's a leak, then a lot of times you'll be able to see where the drape has been lifted up, or you'll hear the air escaping, something like that, and you'll know exactly where to patch it. If you can't tell where to patch it, if this seal check screen isn't up, you can hit seal check and it'll be on the yellow. Take a couple of fingers, go around the edges, and once you've blocked off the leak, it's gonna suck down, or you'll hear the air stop. That'll go to green, you'll know where to patch it. If you come up here and you do this, then you're never gonna know where you need to patch it. You wanna use as little as possible of the drape to patch a leak, because skin has to breathe. And our drape is vapor permeable up to about 3 layers. So if you put layer after layer after layer, it's gonna trap the vapor, the skin's gonna get moist, nothing's gonna stick to it, and it's just gonna perpetuate the problem. So if you have to use more than that, you wanna start over. If it's a blockage, something is blocked in the tubing, inspect the tubing from the patient to the canister. If you find like a blood clot or thick exudate or something in there that's not going forward, you can try to express it towards the canister. If that doesn't work, if it's on the canister side, you can replace the canister. Just hit the eject button, pull it out, get you a new one, put it in there, make sure it's in there nice and solid, and reconnect. If that doesn't do it, then we can replace this tubing without changing the dressing. If this has been taped over, then you can just cut it out. If it hasn't been taped over, it's perforated, you can just squeeze and lift up and it'll detach. And then you can get a new one. And 9 times out of 10, it's gonna be there's a blood clot there, and you can just wipe up with a 4x4, or the person who applied it put too small of a hole or a slit, and you can correct it and put you a new one. Other than that, our guidelines are that if we have a dressing on a patient, there's a maximum of 2 hours without negative pressure before the dressing has to be removed. So if you can't fix the problem, the dressing has to come out. The pump needs to be on and plugged in at all times in the room. There's a short battery life that's really only intended to get the patient, to do PT or to imaging or the OR. When they're in the room, it needs to be plugged in and turned on. Any questions?
Great presentation, thank you.